AAMC with the Alternative Payments team, and AAMC is what's known as a facilitator convener in the Bundle Payments for Care Improvement Initiative, and we partner with Single Track Analytics, headed by John Pierce, here to look at hospitals' Medicare claims data and help them make strategic decisions about their participation in the program. So today we're going to discuss a bit about how we can use data to make more informed decisions. But before we jump in, I'll let John introduce himself.
So my name is John Pierce. Excuse me, I'm the principal with Single Track Analytics, and we are the analytics shop along with our partners at the Hospital Association of New York for the analytics piece of the bundle payment for care improvement program. We're going to go through, I'm going to go through, Jess and I are going to go through some basics on the data for bundle payment and how we analyze that data. We have some examples that we're going to ask you guys to take a look at and see how you would evaluate different episode bundles as just after we talk about how we do that kind of work. And then we're going to finish up with some topics at the end if there's time. So that's kind of the way we're laying things out. So Jess is going to give you a little bit more clinical description of what a bundle is. I just thought I would kind of start with a generic description of what a bundle is. Basically, generically, a bundle is a whole bunch of similar things that are put together. In the case of bundle payments, we've got a whole bunch of payments that are put together under one payment system. Sometimes people go a little bit too far with that concept. You end up with a situation we refer to as being over-bundled. In that case, the provider really has very little flexibility to do anything because of the burden of the bundles that they've selected. This is the bundle of joy, which we refer to as major joint replacement of the lower extremity. The reason we refer to it is just about everybody's making money on the major joint replacement of the lower extremity. There's Bachman's bundle, and this is an important illustration of why it's important to have clinicians on your analytics team, because neither Jess or I have the foggiest clue what Bachman's bundle, given what Bachman's bundle is being. Now, so this is why it's important to have physicians on the team to be able to explain things like that. This is Health and Human Services Secretary Sylvia Burwell, having made the announcement several months ago that Medicare is moving to a much more aggressive value-based payment system, and that bundle payments will be part of that announcement. And this is kind of where we end up with on all of this stuff, which is basically keep calm and bundle up.
So very quickly, a description of bundle payments and bundle payments in BPCI. So as you all know, under traditional fee-for-service, if a patient comes in for a total hip replacement, Medicare pays a separate fee to the surgeon, to the hospital, to the DME supplier, to the post-acute care facility. And that really doesn't create any incentives to control volume or for providers to collaborate for that patient's care. Whereas under bundled payments, a global fee covers the totality of a patient's care for a given condition. And under bundled payments for care improvement, we're working with 30 teaching hospitals that are engaged in Model 2. So bundled payments can differ in terms of how they're exactly paid out. Under Model 2, a bundle is triggered with an index hospitalization and then lasts 30, 60, or 90 days post-discharge. The target is created using a provider's own historical Medicare claims data and then is discounted 2 or 3% depending on the length of the episode. So while you're in a performance quarter, the providers are continuing to pay fee-for-service payments as they would be outside of BPCI. But after that performance quarter, the payments are retrospectively reconciled against the target amount. And if you come below the target amount, the provider gets to keep 100% of the savings, which I'm sure you all know is different than in ACOs. However, they're also responsible for paying back 100% of the loss above that target. And so that creates different incentives than we're used to seeing in some other programs. So you might wonder, why are we doing this session? Why are we focusing on bundled payments? And why are we talking about how to use data within bundled payments? Well, there's a few reasons. For one, bundled payments and BPCI is the most pervasive model out of any that the Innovation Center is implementing. Whereas there are about 600 ACOs, commercial and public, there are over 6,000 providers engaged in some phase of implementation in BPCI. And this is only expected to grow. As John mentioned, Secretary Burwell announced this ambitious goal of moving 50% of traditional Medicare fee-for-service reimbursements to value-based reimbursement by the end of 2018. And we've already seen steps in that direction. So we've seen the rollout of the Cancer Bundle program, Next-Gen ACOs, and in the most recently released proposed IPPS rule, the Secretary is seeking comments about how we would change BPCI if we were to mandate the expansion of bundled payments. And so there's already a lot suggesting that we're only going to move closer to bundled payments than further away. And then finally, BPCI provides a magnitude of data that has not yet been available to providers in the past. So before, where a patient would be discharged and the hospital wouldn't know anything really about the patient unless they were readmitted to the same hospital, now you have data about what SNF that patient is going to, if that SNF is more expensive relative to other SNFs, if it has a higher risk of readmit rates. You know so much more about patients and can use that information to make really strategic decisions about which PAC providers you should be partnering with and how you should be better targeting care interventions.
So the subject of the session was risk mitigation, and we wanted to spend a couple of minutes at least talking about what kind of risk we're discussing. What we're talking about here is basically risk of financial loss. One of the things we talked about when we were planning the session is whether people are looking at legal risk or risk of poor patient care or something like that. If that's what you're looking for, that's not what we're going to talk about here. This basically gets down to whether you're winning or losing on a particular bundle financially. The way we look at this stuff is looking at any type of variation that's out there as whether it's opportunity or risk. So if there's no variation, basically there's no opportunity for anything. If we find variation in costs between episodes, if one episode's more expensive than another episode, can we do anything about that? Okay. If there's something that we can do about variation, that's opportunity. Okay. If it's somewhat predictable, if it's somewhat planned, predictable meaning there's a reasonable, we can predict the occurrence of readmissions with some statistical frequency. Planned would be nobody shows up in a post-acute setting without somebody sending them there. You're not going to show up in a SNF unless somebody sent you there. Okay. And if there's some care plan that can exist to take care of that, that's opportunity. And when we get into looking at the charts and tables that Jess will be showing you a little later, that's what we're looking for. The flip side of that is risk. Risk is randomness. Really, really high cost cases. What are the chances you're going to have a $300,000 case in this particular type of an episode? They're spontaneous. And the questions that we get into with the clinicians is, can you do anything about this? Okay.
So there's a few different kinds of risks, just to provide some context for this. Of course, there's aspects about the patient's condition that the provider knows ahead of time that suggests that this patient is likely to be a high utilizer of healthcare services. That's where you probably need to direct your resources. So that could be things like the patient has known comorbidities, diabetes, obesity, etc. Then there's just random risks that you can't predict. You know, a seemingly healthy patient develops a rare form of cancer or has a heart attack out of nowhere or trips and falls down the stairs. That's less, that's harder to control. So that's something that you would want to have a large volume for to help kind of mitigate the impact of those outliers. And then you also have changes in technology. And this is a special risk for academic medical centers and alternative payment models. So as you know, in many alternative payment models, your benchmark is based on your own historical data. However, academic medical centers are often the early adopters of new technology or changes in care processes, and those are things that are not built into your benchmark. So you don't want to be in a position where you're disadvantaged in an alternative payment program just because you're using a new technology that's probably helping your patients, but not in your benchmark, so it's much harder for you to come below that target.
And so then we start talking about risk mitigation strategies once we know what types of risks we're talking about. The three things that we're going to talk about today deal with episode variation evaluation, episode volume, and we may get into risk track selection as a specific part of the BPCI program, and if we have time, we'll talk about that. So episode variation volume, variation evaluation is how much variation is there in this episode? And we'll show you some charts that we use to evaluate that. If there's not enough variation, there's not an opportunity to create any savings. That happens in episodes like such as cardiac valve surgery that we'll talk about, where it's almost always flat. You have a little bit of post-acute, but there's not much else. The flip side of that is where there's so much variation that you really can't control. And we'll talk about some examples of that too. So you've got to pick a happy medium in the middle where you've got enough variation to be able to create some care changes and therefore some cost changes. But you don't want so much variation that you're just going to get killed by it. I just mentioned that you have to give up to participate in this program either 2% or 3% of the episode cost back to CMS. That's how CMS makes their money. That's the only way CMS makes their money. So there's got to be enough variation in the episodes that you can change for you to get that 2% back, or you're not going to break even. And that's the way we look at this stuff. And then the risk track selection, like I said, we'll talk about a little bit later on if we have time. So when we look at this data, I always looked at this as an analytics guide as what's there and what can you do about it. So if we're looking at a graph, for example, and we'll show you in a second, where there's a lot of green on our graphs, that's SNF cost. Okay, what's there is SNF cost. You'll see a lot of SNF costs, for example, in major joint surgery. You won't see a lot of readmissions in major joint surgery. You just don't have a lot of readmissions. So what's there is not readmissions in major joint. The first thing we're looking at is the what's there. And that's kind of where analytics guys like me stop. Okay, because what I always say, especially to physicians, is I can tell you what's there. You may not know what's there unless I show it to you. But I can't tell you why it's there, and I can't tell you what to do about it. And that takes us into the way that our data team has worked and our clinical teams have worked, which is really, really well. I started realizing early on that sometimes Jess and I or our other partners will be on a call with a medical director or perhaps the orthopedist or the cardiologist, and we'll be going through the data, and we can have a really interesting data discovery session. We can see what's there. But what makes the difference is when Dr. Colin Kimlahan from AAMC is there, that turns the data discovery session into a strategy session. Because then we can start talking about what do you do about this stuff. And that's been very, very evident, I would say, in all of our calls. If Colleen never does this stuff by herself because she doesn't know what's there. But when the team gets together, when it's the three of us or two of us, then we really can get into discovery coupled with strategy.
Okay, so you all have packets in front of you, and we're going to use that for a little interactive session. But before we really jump into it, I'm going to talk through examples of these charts just so you all are clear about what you're looking at and what this data is actually telling you. So these are examples of charts that we use with our hospitals, have used to help them pick what episodes to go at risk for, if they go through a reconciliation to understand what drove either their losses or savings. So we use them every day. Now, volume is not an issue that we're going to deal with specifically within your handouts. We're just going to assume that you all have adequate volume. But we wanted to first highlight the importance of volume in helping to mitigate risk. So if any of our hospitals are looking at a specific episode, if annual volume is below 100, we say absolutely do not do this episode. That if you're below 100, then one high outlier case could just wreck your bundle. You'll have a huge loss. So you need a certain volume to help mitigate the impact of an outlier. And as John was saying, we also are concerned about variation. So how variable are your average episode payments from quarter to quarter? If they're less variable, then you go into this program with a greater deal of certainty and can help sell this to the leaders of your organization that we have a pretty certain idea that this is going to be our financial performance going forward. And to illustrate this, I have two different hospitals who are in our convened group, and their annual volume for PCI in 2013. Now, the height of the column corresponds to the average episode payment for a time period. Each color corresponds to a different provider setting. So, for example, we see on average that the index hospital admission accounted for, the numbers are blurry, but they correspond to like this level of payment. And we can see that for the hospital that had just over 100 episodes annually, very variable across time, whereas the hospital that had over 400 episodes annually, less variable.
Just to remind everybody that this is Medicare, so the hospital's paid on a DRG basis. So that hospital line's almost always going to be flat.
Yes. So here's an example of another graphic that you have in your packet. Now in this case, each line corresponds to a single episode, and still the colors correspond to the provider settings. But here you can look at individual episodes and see what drove that episode's cost. And really what you're looking at here is what color do I see a lot of, and where do I see it? So for CHF, towards the higher cost episodes, you're seeing a lot of red, which is readmits. So that automatically starts telling you things and prompting you to ask the right questions, like, oh, well, can I do anything about readmits, or is this just too risky for me to bundle this episode? Now, I mentioned that episodes are either 30, 60, or 90 days post-discharge. So you need to know where your payments are concentrated across time. And this is what this table shows you. On average, where are your payments concentrated? As you would expect, we see the majority of them happening in the first 30 days post-discharge. However, you might be surprised to know that a substantial portion of them are also occurring after 30 days. And again, you ask the same question, what colors am I seeing and where are they? So for CHF, we see a lot of red, even in 30 to 60 days and 60 to 90 days. And we can talk about what that means when we start interacting as a group. Now again, the common theme, CHF and red, readmits. So you're gonna ask, what's driving my readmits? And this is what this table shows. It shows you the DRG that patients are admitted with for a readmit. So for CHF, you're not surprised, you see a lot of folks coming back in with heart failure, but you might also be surprised to see that you have people coming back with renal failure, sepsis, are those things that you can impact and control or not? And what is not shown, but what you can also see with this data, is how costly that readmit was to you. When I say cost, I mean Medicare payments. But the data allows us to pull up this. We can see the line-by-line reimbursement, and then we can also see what the total episode cost was for that episode that had that sepsis readmit. And then finally, you want to know about your overall payment trend. So this tells you what your average episode payment was from the baseline period, 2009 to 2012, to now. You can either have, of course, increasing trend, flat trend, declining trend. And we want a declining trend because that would tell us that even if we took risk for this episode tomorrow and didn't implement any care changes, we'd probably garner some savings just because our payments have already been going down. But that's not the only thing that we look at. We also look at how variable your payments are around that trend. And if your variation is very extreme, then you need to be able to temper expectations within your organization. One quarter we might generate huge savings, the next quarter we might break even. So that's going to be what you see with a more variable line. However, even if you're really tight to that trend line and there's not much variation, that's not necessarily a good thing either, because you want room to be able to pursue more efficiencies. So it's a nice balance to be able to strike. And We're about to go into our activity, but I just want to pause and see if there's